Hello everyone. So we have a 38-year-old man. He comes to you with the 2-month history of exertional shortness of breath and easy fatigability also. He is taking INH isoniazid, that is a drug for tuberculosis, for latent tuberculosis for the last 5 months. He also has become a vegan for the last 5 months. 5 months, 5 months. On examination, there is conjunctival pallor is there. Area of deep pigmentation in the arm suggestive of vitiligo. Tongue appears shiny and spleen is not palpable. If you go with the lab reports, hemoglobin is reduced. Mean corpuscular volume is increased. Platelet count is in the normal range, but on the lower side of the normal is slightly reduced. Okay. Now, which of the following is the most likely diagnosis? The answer is pernicious anemia. I'm sure many of you have gone for the vegetarian diet also. We'll talk later on why not. The patient's symptom of easy fatigability and shortness of breath, they are the feature of any anemia. And that we can confirm by hemoglobin level of 6.5 gram that supports, but the MCV is increased. That indicate we are dealing with severe macrocytic or megaloblastic anemia. Well, before I proceed further, I have a question for you. Stop the video, write down the answer. What's the difference between megaloblastic and normoblastic macrocytic anemia? We are well aware that these are the two types of macrocytic anemia. Well, the right answer is, for this, we have to see the neutrophil nucleus. Let's say this is the neutrophil, and now you can see the lobes in the neutrophil. In this, we are getting 2 lobes. And now look into this. How many lobes in the nucleus we are getting? How many lobes? 1, 2, 3, 4, 5, 6, 7, 8. So this, to know about megaloblastic or normoblastic, you look into neutrophil nucleus, number of lobes. And if the number of lobes is less than 6, we call it normoblastic. If it is more than 6 or equal to 6, then we call as megaloblastic anemia, right? Now, what are the common causes of macrocytic anemia, whether it is normoblastic or megaloblastic? The mnemonic is A, B, C, D, E, F. A for alcohol, liver disease. B for B12 deficiency. C for compensatory reticulocytosis, which occurs in blood loss or hemolysis. Drug cytotoxic or dysplasia, bone marrow dysplasia. Endocrine hypothyroid and folate deficiency or fetus pregnancy. Lovely mnemonic to remember the causes of macrocytic anemia. Okay, A, B, C, D, E, F. Now, as far as pernicious anemia, this is the most common cause of B12 deficiency, which can cause B12 deficiency. Now, the question is why B12 deficiency is more common in vegan, and which parasite in GIT can cause vitamin B12 deficiency. Stop the video, write down the answer. Okay, why it is more common in vegan? Because B12 is present only in animal diet. It is not there in plants, so that's why it is more common in vegetarians, plant diet. Which parasite can lead to this problem in GIT? The answer is Diphyllobothrium latum, fish tapeworm. It consumes B12. You can see the specimen and the picture. It's a very commonly asked question throughout the world, whichever exam you write. Well, normally Pernicious anemia is an autoimmune disorder, though they may have some associated other autoimmune disease, including grave disease, vitiligo, and type 1 diabetes. Well, when we examine the patient, they have a shiny tongue due to atrophic glossitis. In addition to that, the tongue is swollen, and that leads to macroglossia. Stamping gait, ataxia occurs because of this position sense is impaired. Look into this macroglossia, tongue is enlarged, and atrophic shiny tongue, beefy tongue is there. Atrophic tongue means the papilla which are there in the tongue, they are not there, and there's a smooth surface is there. Now, one more question for you. Stop the video, write down the answer. What are the neurological findings that we can see in a patient with pernicious anemia? Stop the video. Well, when you examine the CNS, we get peripheral nerves, peripheral neuritis. In spinal cord, there can be posterior column involvement that lead to loss of position vibration sense, and that lead to positive Romberg test. Corticospinal tract, upper motor neuron feature are there. And that's why, due to these two are together, we call as subacute combined degeneration. Okay. Point to be noted that the spinothalamic tract which carry pain, touch, temperature, these are not involved, they are saved. Only position vibration sense goes. Cerebrum, it can lead to dementia, reversible dementia. The cranial nerve, second cranial nerve is the most commonly involved, and that can lead to optic atrophy. Patient can also have autonomic neuropathy, which can lead to postural hypotension. How we really talk about postural hypotension? You check the BP in supine position, and then you make the patient stand. You take standing position. If the fall of BP is more than systolic 20 or more, and or diastolic fall of more than 10 millimeter mercury, then we call it to be postural hypotension. Dorsal spinocerebral tract dysfunction may lead to ataxia. Well, there can be possibility to have neurological disease without anemia in 20% of the patients. Okay, now, well, we talked about the dementia occurs. It's a reversible dementia. I have one more question for you. We know very well that Alzheimer's disease is the most common cause of dementia, but that is irreversible. Now, tell me some other common cause of reversible dementia. Stop the video, write down the answer. Reversible dementia. The answer is hypothyroid, and of course B12 deficiency, HIV, subdural hematoma. Okay, they are the four very, very important cause of reversible dementia. So before we take a label any patient of Alzheimer's, it is important to rule out these treatable causes. Romberg test, what we typically, posterior column is lost, we ask the patient to stand, they close the eyes, and patient tend to fall, because in these patients, normally we maintain the balance by eyes or by position sense. And in this case, eyes closed and position sense not there because of involvement of posterior column, they tend to fall, and that is so-called positive Romberg test. Well, in B12 deficiency, despite involvement of corticospinal tract, deep tendon reflexes may not be brisk, but plantar are upgoing. This is due to peripheral neuropathy. Okay, peripheral neuropathy, especially ankle jerk. Normal DTR with positive Babinski sign are the classical thing that we can see. It's something unusual. Normally, we don't see this type of things in a routine upper motor neuron lesion. Now, what we see in peripheral, typically we get macrocyte, megaloblast, and hypersegmentation of neutrophil nucleus. Well, I have one more question for you. This hypersegmentation of neutrophil nucleus. This we see in which kidney disease also? Stop the video, write down the answer. The answer is chronic renal failure. And chronic renal failure, RBC are burst cells. Typically, they are spine-like projection in the RBCs. This is the classical finding that we get in case of chronic renal failure. In addition, we also get hypersegmentation of neutrophil nucleus. Well, you can see the hypersegmentation of neutrophil nucleus, which we can see in any of the so-called megaloblastic anemia. Look into this, RBC size are increased, RBC size are there. But in addition, please note, some RBCs are small, okay, some are like this also. So in addition to hypersegmentation neutrophil nucleus, in addition to macrocyte, we are also getting anisocytosis. Poikilocytosis. Different shape, different sizes that we can see in this lovely peripheral smear. Patient with severe deficiency can also have thrombocytopenia or leukopenia, especially in case of pernicious anemia, there can be pancytopenia. Even the WBC count is, of course, in the normal range, but definitely on the lower side of normal. Platelet count is less than normal. Okay. Now, which part of GIT vitamin B12 is absorbed? What is the name of receptors? Stop the video, write down the answer. Well, the answer is they are absorbed in terminal ileum, and the name of receptor is QBAM. Based on the finding, the patient presentation most likely to be B12 deficiency due to pernicious anemia, and this is due to presence of autoantibodies, because pernicious anemia is a autoimmune disorder. Which antibodies are present in these patients? Stop the video, write down the answer. Well, antibody present in pernicious anemia are, let's talk about immunology. Okay, we have blocking type 1 antibodies. They prevent combination of intrinsic factor and cobalamin. So definitely we all know very well it is this intrinsic factor which causes absorption of cobalamin in the terminal ileum. It is present in 60 to 70% cases, the most specific test. Type 2 binding, it prevents attachment of intrinsic factor to ileal mucosa. It is present in 30 to 35% cases. We also have parietal cell antibodies. It is there in 90% of the patients. It attacks the parietal cell in the body fundus, type 2 hypersensitivity reaction, and that produces a type of chronic atrophic gastritis. And loss of parietal cell lead to reduced HCl and intrinsic factor, because these both are secreted by the parietal cell. Due to this reason, there is achlorhydria. But gastrin level is increased. So low HCl and increased gastrin level is the classical finding that we get in these cases. Now, can it be dietary? He became vegetarian only 5 months back, and liver has a storage of 3 to 5 years of vitamin B12. This much liver has storage, but 3-5 months it will not be affected, causing B12 deficiency. Now, pernicious anemia patients are prone to cancer. Which cancer? Stop the video, write down the answer. Answer is they can predispose to adenocarcinoma. Why and how? This is the lining. Maybe let's say these are the parietal cells. Okay, and let's say this area where parietal cells were there, they have been all destroyed. Why? Because of antibodies. Now this area where the parietal cell have been removed, the body will try to make cells, regenerate cell, but they are columnar cells. This is in response to atrophy of the parietal cells, and this is known as metaplasia. Now, why metaplasia means we are getting a type of cell which is usually not a routine cell of that particular area, and this is known as intestinal metaplasia, and it is this one which is going to induce adenocarcinoma. I told you what type of cancer can develop in this patient is adenocarcinoma. Let's look into other option. Chronic myeloid leukemia is a myeloproliferative disorder of uncontrolled production of mature or immature maturing granulocytes, and massive splenomegaly is there. In our case, the spleen is not palpable. So, and moreover, we are getting thrombocytosis and leukocytosis occur. The WBC count may be as high as more than 100,000 ml. But in our case, WBC count is this, and platelet count is about 135,000. So this is not CML. What about dietary vitamin D B12 deficiency? At the point I only told you this question, normal requirement is 2 to 3 microgram per day, and the liver has a storage of 2 to 5 milligram, and that can last for about 4 to 5 years. And our patient became vegetarian only for the 5 months, so this is ruled out. And our patient became vegetarian only 5 months back. Now, what's the role of intrinsic factor and R factor hepatocorrin? Stop the video, write down the answer in the B12 metabolism or absorption. Well, let's learn the basic concept. In the saliva, we get hepatocorrin. In the diet, B12 is attached to animal protein. In the diet, B12 animal protein, AP is animal protein, and when they come to stomach, HCl break down this combination, and now B12 get attached to R binder, so-called hepatocorrin, and this happen in the stomach. And when they come to duodenum, in the duodenum it is broken down. This is broken down by pancreatic proteosis. P for pancreatic proteosis breakdown, B12 release, and now it combined with intrinsic factor in the duodenum, and finally they come to terminal ileum and they are absorbed. Okay, this is basic. So you can see this R binder in the stomach, and now it bounds to intrinsic factor in the duodenum, and finally in the ileum there are receptors. There are receptors for intrinsic factor. Same thing you can see in the bigger picture. Once again have a look. Diet protein, then in the stomach is a R binder, and it's the intrinsic factor in the duodenum, and finally getting attached to the terminal ileum. Well, we are getting store of 4 to 5 years in B12, but in case of folic acid, it's 4 to 5 months storage is also only is for 4 to 5 months. So now few more questions for you. Stop the video, write down the answer. For the dietary form of folate and how alcohol causes folic acid deficiency. Stop the video, write down the answer. Dietary form is polyglutamate. This can come from plants, animal. P for plant, A for animal. In contrast, the B12 was there only in animal. This is broken down into monoglutamate. And by the enzyme conjugase. Phenytoin, which is an anti-epileptic drug, inhibit this enzyme. With the result, it's not broken down into monoglutamate, and it is this form which get absorbed in GIT. Okay, alcohol inhibit absorption of monoglutamate in the GIT. This is how it lead to folic acid deficiency, including oral contraceptive pills also. The two drugs, they inhibit absorption of monoglutamate. Okay. Look, let's look into other option. INH has two major side effects. One is due to peripheral neuropathy. This is due to B6 deficiency. Second is hepatotoxic. So it can cause sideroblastic anemia because of B6 deficiency. Okay, so it is not related to our patient. Now I have one more question for you. Stop the video, write down the answer. Which other antitubercular drugs are also hepatotoxic? Stop the video. Well, the answer is other drug, rifampicin. Pyrazinamide. There are also other antitubercular drugs which are hepatotoxic. Well, in our patient, there is atrophic tongue is there, and there is low TLC count, thrombocytopenia. The B12 is more likely in these patients. Option D, myelodysplastic syndrome, primarily seen in elderly, but our patient is of 38 years. And pancytopenia and macrocytosis, elevated mean MCV is there. Well, it can be differentiated from pernicious anemia with careful examination of peripheral smear and bone marrow for dysplastic cell. Young age goes more in favor of, not in favor of myelodysplastic syndrome. Vitiligo, which is due to autoimmune process. It's unlikely to be seen in myelodysplastic syndrome. Okay, more seen in pernicious anemia. Let's learn more about myelodysplastic syndrome. Some basic concept. Stem cell disorder involving ineffective hematopoiesis in cell maturation of all non-lymphoid lineage. This is due to de novo mutation or environmental exposure, especially radiation, benzene, and chemotherapy. And they can go into AML. It's a risk. And classically, we get pseudo-Pelger-Hewitt anomaly, neutrophil with bilobe nuclei, typical seen after chemotherapy. Well, what is Pelger-Hewitt anomaly? Stop the video, write down the answer. Pelger-Hewitt anomaly is an inherited blood condition. Well, nuclei of several types of WBC, neutrophil and eosinophil, they are unusual shape bilobe, peanut or dumbbell shape. Okay, normally trilobe or more, and they are coarse and clumpy type of picture is there. This is the typical Pelger-Hewitt anomaly, bilobe nucleus. Golden line to remember, pernicious anemia is the most common cause of vitamin B12 deficiency. It was suspected in patients with megaloblastic anemia, atrophic glossitis, so-called shiny tongue, vitiligo, having associated vitiligo or thyroid disorder, and having neurological abnormalities. Thank you very much.